Welcome to the GAP MASLD MASH Community Network. I'm Maribeth Capuno. I'm an adult nurse practitioner, and I currently work in the hepatology department at the Richmond VA Medical Center.
Just click on your screen one more time.
There we go. Tonight we'll be discussing comparisons of F3 and F4 fibrosis. Tonight we're going to meet Sam. Sam is a 55-year-old male. He's been referred for mildly abnormal transaminase levels and an abdominal sonogram with increased liver echogenicity. He complains of fatigue. And as we found out before, echogenicity is a sign of steatosis in the liver. So Sam's 55, he's Caucasian male, BMI of 33. He has a medical history of type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and he has no alcohol use. On exam, his abdomen is obese, but he has no stigmata of advanced liver disease, such as umbilical hernia or caput medusa. He has no hepatosplenomegaly. Current medications: lisinopril, rosuvastatin, ezetimibe, and dapagliflozin. On exam, vitals: blood pressure slightly elevated at 140/78. His pulse is 76, temperature 98.4. As noted, his weight is 235 with a BMI of 33. Review of labs shows elevated ALT and AST at 85 and 72. Alk Phos is within normal range. Total bili slightly elevated, 1.17, and platelets at 157 are trending down. A1C is 7.1%. Creatinine is well controlled, 1.1. INR is well controlled at 1.0. Ferritin and ferritin saturation are within normal, and ANA mildly elevated at 1 to 80. The remainder of his autoimmune labs and his viral exam are all negative. So once we get all the labs, we want to do our non-invasive testing. And so we'll calculate a FIB4 score, which came out to 3.1. And FIB4 is a calculation looking at age, AST, ALT, and platelets. There's a lot of apps that will calculate this for you, and a lot of labs will auto-calculate it for you as well. His FIB4 of 3.1 is still in the indeterminate range. Anything greater than 3.25 would be considered high risk. He had a FibroScan and was noted to have a KPA of 11, which is a strong indicator of increased risk of significant fibrosis. Anything less than 7 is considered normal. 7 to 9.5 is considered mild to moderate, as discussed earlier in our F1 to F2 discussion. And if it's greater than 12.5, then we definitely presume advanced fibrosis or F4 possible cirrhosis. CAP score of 262 is in the area of moderate steatosis. And then ELF blood test was also calculated with a risk of 9.9, which is a severe elevation, but still not in the range that we consider cirrhosis. So, and any additional testing you might want to consider, and how would you stage him? Based on his labs, Sam would come out to be at least an F3 as far as staging. Platelets are trending down, so you definitely want to keep an eye on that. Additional testing, often if you have access to an MRI with elastography, that would be another non-invasive test that could confirm the level of fibrosis and steatosis. And of course, there's always still the gold standard of biopsy. How would you treat Sam? The first thing you want to do is you want to make sure that you're getting his medical conditions well controlled. His blood pressure and his A1C could both use a little bit of tweaking to help get those back more toward the normal range. Goal for blood pressure would be around 120 systolic and A1C less than 7. You want to help him with goals for weight loss, as his BMI is 33. Anything above 30 is still considered obese. And helping get his weight down also helps any further risk of advancing his fibrosis. You would want to monitor him with CBC, Hep panel. Definitely continue to monitor any non-invasive tests to look for changes, increases. Consider ultrasounds every 6 months because he is F3, and you want to start monitoring for that risk of hepatocellular cancer. You could also monitor an AFP in addition to the ultrasound just to give it a little more weight for your risk stratification for hepatocellular cancer. Another thought is, too, we can also start resmetirom. This is our new drug that's been approved for fatty liver and definitely approved for anyone with F2, F3 fibrosis. We already discussed the lifestyle modifications, and you can consider a GLP-1 for help with weight loss. And as we discussed, monitoring for hepatocellular cancer. Now, imagine we have Sam, but some of his labs are going to come back a little bit differently. So he's still 55, still has diabetes, hypertension, hyperlipidemia, sleep apnea, and no alcohol use. No changes in his physical exam and no changes in his baseline medications. Vitals and labs are still the same. No viral, no autoimmune. But when we go to do his non-invasive testing, we're going to get a little bit different results. So Fib4, we still have a 3.11 because our labs didn't change and his age didn't change. Therefore, that calculation is going to remain the same. However, when we do his FibroScan this time, his KPA comes back at 21. And as we mentioned earlier, anything greater than 12.5 gives you high suspicion of F4 or more advanced fibrosis. CAP score 245. It's actually low, so shows very little steatosis, if any. And then his ELF test came back at 11.4, and anything greater than 11.3 is highly indicative of cirrhosis. Sorry about that jump. So is there any further testing you'd like to perform on this patient? And again, how would you stage him? So further testing, as we mentioned earlier, could be an MRI with elastography to just have another non-invasive test under your belt that can evaluate for steatosis and fibrosis. Or again, you could do the gold standard, which would be a liver biopsy. To stage him based on labs, he would, of course, be an F4 based on his ELF test and his FibroScan. And better to err on the side of caution and treat him as such. So again, with treatment, how would you treat him? You're going to want to do, and how would you monitor him? Treatment again, diet and lifestyle. We still want him to lose weight. We want to get that A1C and blood pressure more close to his baseline. We do want to monitor for hepatocellular cancer with an ultrasound every 6 months, plus or minus the alpha-fetoprotein level. And we want to screen for esophageal varices because with the KPA greater than 20, he has a high risk of having portal hypertension and can develop those complications. So when you look side by side, the Fib4 score is the same, but the ELF score has increased and his FibroScan elastography score has increased significantly. And those are the two tests that definitely are going to be more indicative of F4 versus F3. So as far as how they differ in management, the main thing you want to look for is you're going to look for the sequela of portal hypertension in a patient with F4. So definitely want to do a screening an EGD, a screening EGD to make sure there are no varices. If he does have varices, you could consider adding carvedilol or beta blocker, another beta blocker for prevention. You want to monitor for other sequela of portal hypertension like umbilical hernia, splenomegaly, thrombocytopenia. But as far as management, unless he starts to show signs of decompensation, the management of both F3 and F4 is very similar. You want to make sure you're monitoring those NITs, you're monitoring CBC, hepatic panel, screening for hepatocellular cancer. So the NITs that are probably more helpful would be your ELF test and your FibroScan to differentiate between F3 and F4, because your Fib4 level, once it's above, it's high risk, but it's not always clear cut as to what is going on. If the NITs are indeterminate, that's when you may want to go on to more advanced testing, such as the MRI with elastography or actually a liver biopsy. And hepatocellular cancer surveillance is important at all stages of fibrosis, but definitely we know that there's a high correlation between cirrhosis and the development of hepatocellular cancer. So the more advanced the fibrosis is, the more high risk they are. We have seen at my facility, we've seen people at F0 that have developed hepatocellular cancer. So, I mean, I would consider it always important. Definitely want to get a baseline ultrasound on any patient that's coming in with fatty liver. But definitely at F3, F4, you want to start monitoring ultrasounds every 6 months, because the sooner you catch the hepatocellular cancer, the better opportunities to treat. And I would like to thank you for your time and appreciate you joining us anytime with the GAP MASLD MASH Community Network.